Hello, everyone. Thank you for joining today's session. I'm Dr. Marie-Louise Psarra. I'm a clinical and forensic psychologist. I'm the General Secretary of the Hellenic Forensic Psychiatric Association, HFPA, which is the Greek VIPROM partner. It is a scientific nonprofit organization for promoting forensic psychiatry and psychology in Greece. And we're mainly working with offenders, but also with victims of domestic violence and families affected by it. And my colleague, Dr. Maria Markopilou.
Yes, thank you very much, Marie-Louise. I am Dr. Maria Markopilou. I'm a psychiatrist. I work in Northern Greece. I'm a member of the Hellenic Forensic Psychiatric Association, and so glad to be part of this European webinar. So let's go back to you, Marie-Louise, to start with the presentation, and I'll take part in the next slides and videos.
Okay, thank you, Maria. So in this webinar, we are talking about communication and its role in cases involving domestic violence. We consider this very sensitive and very important issue, and we consider the way we respond, the words we use, our tone of voice, the body language, that really makes a difference in whether someone feels safe enough to open up and discuss about a very really negative and very exhausting situation as it is domestic violence. So we'll be focusing especially on how these issues, how conversations and communication in regards with domestic violence come up in some specific healthcare settings, such as pediatrics or obstetrics and gynecology, where, professionals are often the first or the only one even to notice signs of abuse, or the first that victims feel comfortable speaking to. So the question we'll keep coming back to throughout the session is, how can we make communication safer, more effective, and more compassionate in these difficult situations? So here's a look at our agenda today. First, I'll give a quick recap on why communication is so important in healthcare in general, but especially in DV cases. And we'll look at what might prevent someone from speaking out about domestic violence, some of the things that may not be so obvious at first, but really shape up the conversation and the interaction between the healthcare professional and the patient. And after that, we'll dive into communication strategies. That is, what can we do? What can we say? What we should avoid saying, of course, and how can we build trust in a vulnerable situation like this? And we'll also explore how to respond appropriately when someone discloses violence and how to adapt our approach depending on the case, whether it's a case of sexual assault, a gynecologic consultation, or working with a child in pediatrics. And of course, towards the end, we'll open the floor for questions and reflections you might have. So by the end of this webinar, hopefully you should feel more confident in a few key areas. You'll be able to recognize the hidden or not so obvious barriers that stop someone from disclosing domestic violence. And you'll learn how to respond in a way that feels safe and supportive. And hopefully you'll know how to ask the right questions in the right way and in a timely manner, and how to offer space for the person to speak and to disclose his or her experience. And you'll also learn how to use visuals and nonverbal communication to show support, because sometimes a poster on a wall or a kind gesture can do much more than words can do. And perhaps most importantly, you understand what to do next, because once someone opens up, they need to know we are there to support them, not just in that moment, but moving forward. So to build trust in the long term. And we're talking about communication, but why is it so important? It's been established, and we know it from our clinical experience, but also from research, that when someone is experiencing domestic violence, they are often live in fear, in isolation and shame. They may feel completely alone, and usually that's the case. And so the way we talk to them, the way we listen, how we respond, can be a turning point, a turning point that helps them either reach out for help or shut them down completely. And effective communication is essential in order to offer a full and supportive care, because care is not only about treating traumas and injuries, not only the physical and not treating only the body, but it's also about a comprehensive and a holistic situation. So we need to understand how complex disclosure can be in such cases and respond in ways that make the person feel safe. And we'll be talking a lot, and you'll be hearing me say a lot about safety, because it's the most important issue, because safety is the one that is hurt and broken. So we need to restore that for the patient. So that's why we need to communicate in a way that it is trauma-informed, meaning recognizing that trauma affects how someone talks, how they behave, how safe they feel. And a trauma-informed approach means shifting the question from what's wrong with you, what's the problem with you, to what happened to you. And it is a really important shift. And we must understand our patients, both their past and their present, in order to care for them appropriately and thoroughly and comprehensively. And it's been established that adopting a trauma-informed approach can potentially improve not only communication, of course, but also patient engagement in therapy, treatment adherence, and health outcomes in total. So, and also it helps the provider and staff wellness, because that's important too. So it's also, communication is also being patient-centered. Patient-centered approach means involving patients and their families in decisions about their care, sharing information openly, and making sure care is easy to access, because we may be there, but if they can't have our, if they can't take the whole of our approach and care, it's useless. It's about respecting their choices. It's about respecting their pace and including them in decisions about care, not making assumptions, but making decisions along with the patient and their surroundings. And finally, we must be gender sensitive. The communication must be gender sensitive, and it's important to create a gender affirming experience, beginning with communication. It is essential in healthcare settings in general, but especially in domestic violence, where safety and affirmation is always broken. Especially when talking about domestic violence, using the correct pronouns, respecting someone's identity as a whole, and not making assumptions based on how someone looks or how someone sounds. These are small details but they have a huge impact, making people feel heard and respected and safe. And before I move forward, it is important to note that our communication style plays a crucial role. I mean, not only in general, but how we, as every one of us separately, has a communication style. So let's take a moment to think about how our own style might influence the way others respond. It's not only how we respond to someone talking to us, interacting with us, a patient, I mean, but also how our words, the way we communicate, affects others. For example, are we naturally direct? Are we gentle? Are we tending to lead the conversation, or do we wait and listen? We all come from different places and experiences. We have our own habits, our own tone and pace, and the ways we ask questions. And while some patients respond well to a more direct approach, others may shut down completely. The same words can land very differently to different persons depending on how they are said and by whom. So for instance, someone who is very quiet or has experienced trauma might feel very overwhelmed by a very authoritative approach, a very direct approach, or on the other hand, someone else may feel safer this way. He may feel safer with clarity and direction. So there's actually no right way, but there are some things that are right to say and do and some things that are not okay at all. But we need to adapt. So I encourage everybody, including ourselves, to think how might patients experience my communication style. And we have to consider both. So this is especially important in DV cases because survivors often scan for signs of safety. And that means we need to adapt, not just apply a general rule book, not a one-size-fits-all model, but we may consider asking ourselves, am I being too clinical or detached? Am I perhaps too warm and making the patient feel uncomfortable? Is my tone neutral, respectful, non-threatening? And most importantly, can I shift when it's needed to meet them where they are emotionally and psychologically? So it needs adaptation. I already said that there's no right way, but there are some things that we can do better. And on the other hand, there are many things and many challenges that can make for a patient difficult to people that experience domestic violence may face many challenges when reporting or disclosing domestic violence and abuse. I mean, there's always the question that we come up and we encounter, especially in healthcare settings, why don't people speak up sooner? Or why don't they speak at all? Why do they let themselves be abused and never tell everybody? And it's a question that we often hear, but I think the answer is really simple. And it's always the same. The answer is that speaking and disclosing something like that, it's really complicated. And it's complicated because there are some barriers, some things that hinder people from disclosing domestic violence. Some fear what might happen next. I mean, more violence, escalation of violence, losing custody of their children, being judged. Others feel deep shame or blame themselves for the abuse. Some people just don't trust healthcare professionals because of past experience, bad experiences, and we all been there. We all have our own past experience within healthcare settings that are not that positive, or because they have been told that doctors aren't the right people to talk about these. Hospitals are only for treating injuries, not discussing about domestic violence, and so forth. And there are some practical issues that may inhibit disclosure. Maybe victims depend on financially or otherwise on their abuser. Maybe they have no alternative housing, no place to go. So when we don't see someone speaking up, it doesn't mean that they're not suffering, that there is no abuse. It just means they haven't yet found a space that feels safe enough to do so. And let me add something else to this list of barriers. Internalized beliefs. I think that it's not something that we may think that is not very obvious, but the belief someone might hold about themselves or their situation may prevent them from reaching out. And usually, and in most of the time, survivors don't even may not even recognize that they are experiencing something that they would call abuse. They carry deep-rooted thoughts like, maybe it's not abuse if I didn't end up in the hospital, or it's not really abuse unless there are bruises and physical injuries. Or we just fight sometimes, that's normal in relationships. Or if I leave, I'm a failure, it's my fault. You know, these deep-rooted thoughts that they don't just come up from nowhere. They're shaped by upbringing. They are shaped by media, by community beliefs, by community rationales. They are shaped even from past healthcare interactions. So part of our job, I think, it's not just to hear the words being said, but also to recognize what these words mean for each individual. So what someone believes about their own worth, about their situation, and gently challenge this idea that they did not deserve better, that they are not abused. We have to not only to understand what they believe, but to understand what this belief mean to the individual. So that's why asking a question like, are you experiencing violence? Are you abused? Sometimes might be helpful, but it isn't always enough. So we need to explore it gently and ask things like, do you ever feel afraid at home? Or how would you feel if this was happening to someone, you know, a close friend or another family member? And so helping them shift their perspective and help them recognize that what they're experiencing is not okay, it is abuse, and that they deserve better. And it is our job to do so. I think I've done talking a lot for a while, and I would like now for you to watch a video, two videos in fact, short ones, and because we have a time issue, you know, we have to do that in 1 hour and include as many information as we can. But I would like to show you two short videos that we prepared. So bear with us. It's not a professional job. It's not. We are not actors. We're not directors. But we wrote two scripts. And we performed two role-play videos that show a doctor-patient interaction. And as you watch, I invite you to pay attention to the tone of voice, the body language, or the words that we choose to share with the patient, and to reflect on whether the doctor listens actively, whether there is empathy in the tone of voice and you know, the whole interaction, what went well and what felt off, or what wasn't right. And let us have this as a chance to critically think and see communication as a whole, not just as words, but as an emotional exchange and as a whole experience. So let's watch the video and have this in mind. So for you to really reflect on during the video. Doctor, can you give me a week of my work? I don't feel very well.
Are you a victim of domestic violence? I ask you about violence because usually women with such traumas are victims. Even if you feel uncomfortable, it's better to talk about it. So please answer my questions.
Well, okay. Sometimes my husband yells and gets, you know, nervous.
That makes you sad, doesn't it?
Yeah, but...
Somehow you could have avoided the situation.
No, I just told him I want to go to visit my mom.
If he's nervous, why do you irritate him?
Well, you're right, but I haven't seen her in a month, and...
Anyway, I think it is a common, typical male-female behavior, crying. There's no need to overreact. Calm down. For God's sake, calm down.
I don't feel very well.
These feelings will pass, don't worry. You are lucky that nothing worse happened. So stop feeling so bad. But why did you still stay with a man who treats you like that? You absolutely must get a divorce.
Oh, no, I can't. It's the kids. How can I raise them on my own?
If I were you, I would go to the police and file a complaint. You should definitely call this number and leave your husband immediately.
I can't right now. I feel like shit. I feel crap.
What should I do now? If you had come earlier, I would have helped you better. Anyway, I'll give you a sick leave for 5 days.
So there are a few comments very targeted to the topic we're trying to address in this webinar, and I'll try to summarize it. Many of you have mentioned that the doctor didn't remain in contact with the patient. He didn't have eye contact. He didn't help her open up. One of our colleagues commented that she felt that the patient was attacked actually by the doctor. He didn't offer the safe space, and he didn't have anything to propose to her, the way that she can get help. The patient remained without answers. Of course, a colleague of ours said that the doctor asked her about domestic violence, but maybe not in the right way. He asked, but maybe he didn't seem to pay attention to her answers, and he didn't go on with follow-up answers. And if I may comment myself, he was patronizing, I think. And he had some thoughts of his own about what she should do. So he was quite patronizing. Some of our colleagues commented that maybe the doctor not only didn't help her open up more, but she felt more intimidated after this examination because there was no connection, and he didn't listen at all. So, Marie-Louise, I think that the video demonstrated very, very well what insensitive and not empathetic practice looks like when examining a patient coming to us for another reason maybe, but there is an underlying domestic violence.
I was wondering if our colleagues and participants think that this is a usual case, because from our experience, our clinical experience in a general hospital, it is quite common, but I don't know if it was shocking for people to see. Of course, it's an exaggerating video trying to show what not to do, of course, what to avoid. But I think that in most cases, it looks like that, it sounds like that with many doctors because of time, because of the notion that it's not their job to deal with domestic violence, because of not knowing how to communicate effectively and in a positive manner. But unfortunately, it's not that rare of an interaction. So let's move on to the other video. So let's do the same here and reflect on the same things of this new interaction that you'll be watching. Reflect on the same things, what was well, what went off, what's not right or what's right, and how this interaction goes.
Hello. Doctor, can you give me a week of sick leave? I don't feel well.
Well, I understand, and we'll see about that, but may I ask you some questions before? Okay. I noticed that you came here with some injuries, and I know that many people face problems of violence in their relationships. That may be the case for you too? I know it's hard to talk about these things, but it's safe here. You can talk to me.
Well, okay. My husband sometimes yells and get angry with me.
So,
Nervous.
yeah, I understand, but has he verbally or physically hurt you in this way? Are these injuries that you came here for caused by your husband? You must be feeling very scared. Has anything like this happened before?
Yes, when he drinks or gets angry, he hits me. But I know I have, it's my fault because I annoy him. And
No, it's not your fault. It's his behavior. But You told me it's usual and he hits you when he gets angry. Can you describe how?
Oh, well, it's very difficult, but the usual. He pats me in the face, he hits me, kick me, and the last time he pushed me to the closet and tried to choke me.
Okay, okay. It must be feeling really hard and it's very difficult for you. But you said the usual. So do you feel that you are in danger in this relationship?
Sometimes, yes.
I understand. Is there anything I can do to support you?
I don't think that anyone can do something about this.
Yeah, but is there a safe place for you to go in case of danger, of an immediate danger, I mean?
Look, doctor, I can't leave my house. I have 2 children, and I think that he will hit us, and I don't want to something like that.
Yeah, however, I want to help you stay safe and healthy, and I want to give you these leaflets. I give it to all my patients with injuries like that. Please take them and read them, but make sure that it is safe for you to take them home in case he finds it, you know?
What's that?
Or there are leaflets that contain information about what you can do about that and where you can go for help, you know, the next steps.
Look, doctor, I can't report to the police right now.
I understand, and it's a difficult decision. You don't have to make it right now, but I want you to know that we are here. You're not alone, and you can come anytime for help, not only for the injuries, but for anything else, for you to stay safe and healthy. Okay?
Okay, thank you.
Be safe. So let's take a moment to reflect on that as well. What we saw, it's a normal situation, and in healthcare settings, in hospitals. And is there anything you noticed different from the previous video, or something that you depicted on being positive or negative in this interaction?
So, if I may summarize your comments, all of our colleagues found that this version of communication was quite empathetic. Most of our colleagues commented on the way the doctor approached this patient with his whole body, his voice, and of course the way she approached her. One of our colleagues commented on how important it is that they are both women, and all of the participants found that the doctor was welcoming, he was interested in the patient, he was not judging her. He offered the leaflets, and she seemed to really care about the patient's safety. She seemed to really care about what's happening, and she gave her something to take with her if she wants, or just read in the waiting room. And of course, there was a great difference because here the doctor is not patronizing, it is not judgmental, is empathetic, and employs many communication strategies. And in the beginning, of course, she normalizes the situation. She says that I ask everybody these questions about domestic violence because it can happen to anyone. So she opens up the discussion. And of course, she notices the bruises, and she makes a choice. She doesn't ignore them. She addresses the issue and asks in a very with concern about what's happening. And of course, it's very important that the doctor clearly stated that the violence was not the patient's fault, but otherwise she did not judge any of the other answers. And she's very warm. That were the comments in the chat. Of course, there is a question by Professor Douzenis, who asks how can this be better? Maybe can we have a better version of this better version of the other video? I think that maybe she can close the discussion giving her a follow-up. A follow-up maybe in some days or weeks to keep in touch. She makes a great effort to make her feel safe. She says that this is the place to talk about domestic violence, and I'm concerned, and maybe she can give a follow-up in maybe the next few weeks.
Thank you, Maria. I think I'll wrap it up and actually answer this question, how to do even better, because of course it's there is great difference between the two videos, but we always can do better than that. And let's see how. So let's talk about practical strategies in order to foster respectful and trustful communication about the experienced violence. We have first and most important of all, ensure that the victims have a private space without any accompanying individual, either a partner or children or other family members or non-family caretakers. We know from clinical experience and from research that usually the abuser accompanies the victim in the healthcare setting, so that to make sure that the victim doesn't speak up, that doesn't disclose violence, and to make sure that there is control and silence about the abuse. So we need to make sure that the patient has a private space. And of course, we need to have open-ended questions, ones that invite conversation instead of yes or no. For example, we might say, can you tell me more about what's been going on at home? And follow up gently and let the answers guide the next question and the next interaction, the next step. And of course, we have to pay attention to small emotional clues. A sigh, a hesitation, or a vague comment might be a signal that there's more behind the surface. And we saw that in the second video, that the patient asking for a sick leave was it was a hint that something's wrong, and the doctor picked up that line and asked about domestic violence. And of course, as Maria said, we should normalize the topic and say something like, I ask all my patients about their home life, their relationships, because it can affect their health. So we have to normalize the situation and to point out that violence may affect generally the health of someone, and not only to have physical bruises. And of course, we need to slow down and leave pauses and leave room for silence, and of course avoid judgment and just be present. And there is also one thing I'm trying always to keep in mind, and it's in regards with culture, that it plays a massive role in how people interpret care and communication. In some communities, privacy is sacred, and disclosure outside the family is considered a betrayal, or in other cases, honor and shame can even override the personal safety. So we have to be culturally safe and respectful. This means not making assumptions and asking with respect about what someone feels comfortable with, and being aware of community dynamics and stigmas, especially around gender, sexuality, or family roles. And I think culture and cultural safety goes beyond just being aware of someone's background, to know its gender, the sexuality, the family roles, but it is to acknowledge how someone's beliefs and community norms or fears might impact their willingness to disclose and to speak up. And so we might ask and say, for example, in your culture or in your family, how it is usually seen when someone speaks about problems at home? So this question invites conversation instead of judgment. Why don't you speak up? Which is the usual comment in such situations. And I've mentioned that we need to make sure to see the patient alone, and it's one of the biggest challenges, that separating the patient from the person who actually may be harming them. And especially when they come together, and it's usually the case. So we'll try to always see the patient alone, and if the abuser is in the room, of course, you can understand that there's no freedom to talk. So we need to create a reason to separate them. For example, we can ask the partner to step out for a procedure or for filling up paperwork. And we can say things like, due to the nature of this exam, we'll ask all visitors to wait outside. Or something like, this part of the checkup needs to be done privately. And if there is a language barrier, we never use a friend or family member to interpret. It's not safe, and we should always opt for a trained interpreter. Ideally, someone who understands the DV context, or someone who comes from a DV support service. But we should also keep in mind that cultural matching it's not just about language. Sometimes an interpreter from the same community may create even more fear. Survivors and victims may worry about gossip or shame. So we should always ask the patient and the potential victim, would you feel more comfortable with an interpreter from outside your community? So we need to pay attention to both ways. So cultural safety it's a two-way street for us. And sometimes the way we sit, you already mentioned that in the comment, that the way we sit, the way we look at someone speaks louder than our words. So we have to sit beside the patient or across them, but near, and not behind the screen or behind papers, and lean gently forward. Of course, keep an eye contact, but without staring, without being eye intrusive, and avoid cross arms, and show that we are listening, so echoing their words, but also nod gently, and use our whole body to show that we care and that we are there and we want to help them. And sometimes even not our body, not our language, not even words may seem enough, so visuals can help. So it's really important to create a space that it says and it shows that we can talk about domestic violence there. For example, place information with support services, or information regarding domestic violence in waiting rooms, in washrooms, in bathrooms, in places where people can see them, and which gives the meaning, the message that it is a safe space to talk about domestic violence. Of course, and you watched that in the video, to comment and mention that that patient may take that, but warn them not to take them if that's not safe, if the perpetrator could find them, and so that the violence may escalate. So posters in bathrooms, brochures, discreet cards as the ones you see here, professional cards when that may seem like a professional card, but actually they contain information on shelters or information on support services. And this sent a message that the space is safe to talk about domestic violence, and that and they make support services readily apparent and easy to for the victim to see. But when we use these visual communication items, we have to use images and materials that are not stereotypical. They are inclusive, they are non-violent, and they are positive. If they're in multi-languages, that it's more helpful, and we should use simple and clear language, and trying to keep in mind that for someone scared to speak and talk about domestic violence, a visual cue may be the first step to reach out. And you see here the international sign. It's a single-handed gesture used to draw attention to domestic violence, and it can be employed when a person in need of help cannot speak loudly. For instance, when the abuser is in the next room or someone near. So the signal is performed by holding one hand up with the thumb locked into the palm, and then holding the 4 other fingers down. It means that symbolically we trap the thumb by the rest of the finger, meaning that there's a problem, there is domestic violence occurring, and it is a sign for help. So beware of that. If you see that, it means that the person is in need. And we talked about how to create a safe space, and what about when actually after creating a safe space, the person decides to disclose violence. So when someone actually speaks up, the response matters a lot, maybe even more than before. So first we have to listen, really listen, and do not interrupt. We should avoid asking why questions or pressing for details, and we should reflect their words back. For example, it sounds like you're scared, or for example, you mentioned that you are being hurt. Can you tell me more if you feel ready? And of course, not judge. And we should offer comfort and validate their feelings and assure the person that their emotions are typical, they are normal in situations like that. And we can say things like, you didn't do anything to deserve this, you're not alone, help is available, but only say it if it's actually true and that you can actually follow up. And we should not jump into advice or solutions, because sometimes the victims only need to be heard and feel safe. So empower them to express their needs. For example, asking, what would feel helpful for you right now? What can I do to support you? What can I do to help you? And if the victim is not ready to talk about the situation, we should not force it, but recognize that there is a right time, and let the victim know about it, and of course follow up. Follow up is very important, because actually building a trustful environment doesn't stop when someone discloses violence. It's even more important to remember the interaction, especially when disclosure doesn't come from the first time, and it's usually not the case. Maybe a person needs 3, 4, or 5 appointments to speak. Maybe the victim may never speak actually, but it's important to follow up on questions. And for example, if we have an interaction like that, even if there's no disclosure, but there is a suspicion of violence, and the victim comes up after 2 weeks and we don't even remember the name or what it's been said, all the trust that we have created, it's gone. So it is important to follow up, maybe with a phone call or a follow-up appointment, in order to for the trust to remain and for the person to feel safe to eventually speak up if that doesn't happen from the first time. And it is important in cases where sexual assault has taken place to be even more gentle, even more attentive to our tone of voice, our language, our empathetic listening, because when sex is involved, the things are even more sensitive, and we need to be even more careful. So questions like, has anyone ever touched you in a way that made you uncomfortable? Or has anyone ever made you do something sexual against your will? Or has your partner refused to use protection or remove protection during intercourse? Are things that we can ask in order to specifically address sexual assault in the context of a relationship, in the context of domestic relationships. And a very specific and equally sensitive situation is during pregnancy. We've established by literature and research that during pregnancy is a very dangerous time for a woman to be hurt and to be abused by a partner. So in consultations with gynecologists, patients may be even more afraid and unsure. So empathy and tone of voice and pace really shape the experience.
I think it's important to observe this video too, because he uses many techniques in a very professional way. Okay.
Katie, as part of our initial assessment, we ask all women the same questions about family and domestic violence. We know that violence in the home can occur to pregnant women, and sometimes for the first time in their relationships. Are you okay if I ask you some of these questions?
Yeah, sure.
Just so you know that what we do discuss today is confidential. We will be recording it in your personal medical record. However, if I'm concerned about the safety of you or your baby, then I may need to contact an external service. Is that okay?
Yeah.
Okay. So, Katie, has anyone in your family or close to you ever put you down, humiliated, embarrassed, tried to control what you say or do?
Well, I'm not sure if this is what you mean, but Mark likes to know where I am all the time. He doesn't do it to be mean, he's very protective of me. He cares a lot for me and the baby. If I ask him, he lets me go out. It's no big deal. He doesn't do it to be mean.
Okay.
And, well, I've been really tired lately and doing stupid things. And Mark gets really angry. I know it's part of pregnancy, but Mark gets really angry and calls me useless and stuff. I don't know how I'm going to be as a mum. Useless, probably. Just so tired all the time and unmotivated, and the baby's not even here yet. I don't know what I'm going to do when the baby finally comes. Yeah, it's just all a bit overwhelming sometimes.
Pregnancy can be a really stressful time for everyone. Katie, can I ask you, what do you mean by that Mark lets you go out if you ask him?
Oh, just normal stuff. Like if I want to go to the shops or go to appointments like this. Yeah, just normal stuff, really. He just cares about me, so he needs to know where I am all the time.
Okay. Has Mark ever hurt you or threatened to hurt you?
He's never actually hit me, but he can get a little bit rough when he gets angry.
Katie, what do you mean by when you say Mark gets a bit rough? Can you give me an example?
Well, he likes to throw things around when he gets angry, and he did push me the other day, but it wasn't that bad. He does throw things at me, and lately he's been calling me a selfish bitch a lot. He's just under so much pressure with work. He's a policeman, so yeah, his job's really stressful. The pressure as well of me not working. Mark thought it would be best if I stopped working. He's very protective of me. And that pressure, I think he's getting pretty freaked out about it all and the baby, especially considering it wasn't planned. And he's got another 2 kids as well with his ex. I think he's getting depressed. He's being very paranoid as well. He accused me of having an affair the other day, which is ridiculous. And he's been checking my phone a lot and my email, and he has to know where I am and what I'm doing all the time. But I know it's just because he cares about me. So it's fine. It's normal.
Katie, these behaviours don't sound normal to me. Abuse can take shape in many different forms. It doesn't have to be physical violence. Sometimes these behaviours can also escalate during the pregnancy and continue after the baby is born. Katie, I'm quite concerned about some of the behaviours you're describing that Mark is doing, like controlling things and taking your phone. That sounds quite abusive to me. I do have some information that I can give you today, and I can also get in touch with one of our social workers. Would you like me to do that?
I don't have time because I told Mark I'd be home by 12, but maybe another time. Would Mark have to know that I'm doing this?
No, that can be confidential. We don't have to do anything today. We can talk to one of the social workers at our next appointment. I can also give you a booklet that you can take with you today. You don't have to take it home. You can read it in the waiting room. It's about finding help, and there's lots of information for women in there. There is the domestic violence phone line. It's a confidential phone number that you can speak to somebody 24 hours a day, 7 days a week.
Okay, thank you.
Katie, I really appreciate your honesty today. I am concerned for the safety of yourself and your baby. Do you think that you're safe to go home today? Yeah. Okay. If you would like to make an extra antenatal appointment to see someone, then please feel free to do so. Okay. Thank you.
So have you seen the the best way, and we can discuss this later. What was and it is an answer, I think, to the question of how can we do even better. So we'll have the time eventually later to see if you depicted something that was really positive. And I would like to say a few things about pediatrics, so about child abuse. What we've said up to here really since when we are talking about child abuse, so with children, it's a totally different kind of listening and communication, because abuse manifests in the diverse forms, and the impact on each child differs a lot. So not all cases involve visible injuries, and usually we have this notion, this myth that children make up stories about abuse. Literature and research shows that that's not the case. Usually when children lie, they lie about something good, something positive, and not about abuse. Maybe they will change some aspects of the story, but the core of it, when they disclose abuse, it's almost always true. So we need to make them share their experience, but not feel interrogated by the healthcare professional. And we should allow for crying to happen, or for silence. And we need to make the space really, really safe for a child to speak up. So we can ask questions like, is there something that makes you feel scared or threatened by what happens when someone at home is angry? So general questions and gentle questions that allow for a child to speak. And we should make sure that we have that they have our full attention, that we don't interrupt them, we don't rush them, and that, of course, that we believe them, and we do let them lead the conversation, but reassure them that we are there. For example, we may say something like, I believe you. I'm glad that you came to me. I'm sorry this happened to you. It's not okay. It's not your fault. Thank you for sharing this information with me, and I'm here to listen and support you. So to make sure that they know they have someone to talk to. And we should be super listeners, especially with kids in all situations, with all of our patients, but with kids, it's really more sensitive and more case specific. So we need to be extra more careful. And before we close, one little thing, but that it's not that little, it's quite important. And we should also pay attention to the other part of the equation in the interaction of a victim or a patient and the doctor or the healthcare professional. There's also us, the professionals, and we also take care of us too. Because, hearing about domestic violence and working with survivors and hearing their stories and being the holder of their pain and feeling responsible for their safety, it's really burdening, and it can really have a toll on us too. So we may feel emotionally drained, hypervigilant, we may feel detached from our own emotions and relationships. So please, when you deal with such cases, when you deal with cases of domestic violence, please make sure that you take care of yourself too. It's not optional, it's an ethical choice. It's a choice that make sure that we don't get burnout as well, because if we are burnout, we cannot help anyone, let alone a victim of domestic violence, which poses a burden, an extra burden. So if something feels heavy or triggering, it is very okay to step back and seek support and debrief with a trusted colleague and ask for professional supervision, and allow space for feelings and emotions, and keep know our limits. It's important to know our limits and to respect them and not just power through, because we are human, and these feelings don't mean that we are weak or we are vulnerable, but it just means that we are human, and it is okay for us to seek help too. And now I'm done talking, and I'd like to hear from you for your reflections, for your questions, for any comments, or something that you need to clarify. Thank you.